Everyone. My name is Ramkumar. I'm Secretary Health and Secretary Health in Government of Meghalaya. I would like to take you through the very important and significant story of the state where from a place of having a very high maternal deaths and infant deaths, we've been able to reduce significantly over a period of last 5-6 years. So I'd like to take you through that by giving the situation of the scenario of the state. So where Meghalaya stands, this is as of 2011 census, some numbers might change. So you can see Meghalaya is almost about 30 lakhs, now the population is expected to be about 40 lakhs now. And we have very low density population, but compared to Northeast, it's still somewhere in mid. But most important point, I would like to all of you to look at the 80%, 79.5% rural population. 80% of the population of Meghalaya lives in rural areas. People think when they come to Shillong and etc. and have a very beautiful look of Shillong, Cherrapunji, they think it is very urban, but it is mostly rural in nature. And another important thing is the number of villages is about 7,000 in Meghalaya, which is the highest number of villages even for among entire Northeast, higher than even Arunachal. For a similar population state like Manipur, it is about 3,856 and Meghalaya is 7,000, which shows service delivery of any kind is going to be very, very difficult in the state because of the nature of the geography and the nature of the population dispersion across the state. This is where the maternal and health indicators, child health indicators used to be there for Meghalaya. Maternal deaths in 2020, we had 244 maternal deaths, literally about 5 deaths in every week we used to have. And the number of antenatal checkups mother used to get less than, at least 4 was less than 50%, around 50%. Infant mortality was higher than national average. Anemia is very, very significant. And institutional delivery used to be less than 60%. Most of them, or under 40% of them delivered at home, and very high levels of stunting among and wasting also among children. And this is just to give a snapshot of the geographical problem, where about 7,000 villages, about 25% of the villages can be reached during a day like this. You can reach only through by a 4x4 vehicle. You will not be able to reach easily by even a bolero or other day. Even during winter days, it should be fine. Even among them, 417 villages can be reached only by foot on any given day. They do not have a direct road access. And in Meghalaya, like in many other northeastern states, new villages start coming up every year, because of the kind of cultivation, Zoom cultivation, some practices are there, and that is also another very, very key issue in terms of service delivery. So when we did an analysis of 244 maternal deaths in the year 2020, during COVID, we took this up a challenge, saying that this many deaths are not acceptable and we need to look at it. So these were some of the very important points which we got. I'll go from reverse. 92% of them were from very poor households. So social determinant became very, very important. 40% from hard to reach areas, which comes under the 1,700 villages we spoke about. And 49% were at home or during transit. 1 out of 2 deaths were either at home or transit. So home deliveries were a serious issue. And you can see 40% were more than 5th gravida, which means an average pregnant woman in Meghalaya was carrying her 5th child. And 50-60% of anemic, and a large 18%, very high number of teenage pregnancies also. So we identified many areas actually of intervention, but 5 broad points of policy where the issue was not discussed at the levels which should have been discussed, or the sufficient discussion. Here I would like to remind that our Chief Minister, Shri took this as a big challenge and spoke about this on every floor when he got, and he inspired the entire cabinet and the entire government to take this up as a very, very important issue. And it was also considered only as a health issue. It was not seen as a social issue or even an economic issue. A mother dying puts a lot of stress on the family, economically and socially, and children are at a lot of disposal of the community to take care, or the family, the extended family to take care of them. There was a lack of real-time data. There was insufficient support and autonomy to the health teams to take up the issue at their own level. In a place like Meghalaya, where the population is very widely spread out, the decisions had to be taken up on the ground at by the person who is present at the moment there. The decision might be right or wrong, but they have to take the decision, because the moment the decision making goes up the chain, definitely the decision is not going to come in time. So we had to prioritize the issue and then strategize on solving these 2-3 other main areas of concern. Through this, there was a state capability model which was built. So this is the most important slide of this presentation, because We have a lot of issues in the governance and in society, but everything cannot have a piecemeal solution. How do you build up a solution which has to have the framework can be suitable for any problem, be it environment, be it childhood nutrition, be it even problems like economic development. How do you have this thing? So these 5 pillars, the credit goes to our Additional Chief Secretary, Shri Kumar, who is not here, unfortunately, because of other commitments. The main important thing was, again, I'm going on reverse, to build the political support. Any issue or any matters need to have that political support within the system. Because in many situations in our system, some of them are bureaucratic driven or some of them are individual leadership driven. Here we wanted to have it collectively. Address systemic challenges in terms of procurement, recruitment, all those things were their issues. So that was very important. Very important use of data and technology. Data should not be a point of discussion, but data should be a point of action. So that is where we arrived at a single point. I will explain a little later. And local leadership through community building, solving problems, meaning both medical officer level, as well as the district health medical officers, medical superintendents level, as well as the community level. And citizen-state relationship. Here again, the community comes a very important point. How do we convey this issue to the community? How do we take their issue as priority? How do they consider this? How do they perceive this entire issue of maternal and child health and etc. and bring that into our perspective? It's a very important issue, and that's most important in terms of crux even within this pillar framework. So regarding data, we set up a portal. It's an open health portal. I think we are probably the only in the country where anybody can it's an open dashboard. You can go and see in which village, how many pregnant women are there, how many of them are high risk among them, and what is their, when are they going to deliver, not by name, you cannot find anybody by name, by number you'll be able to find, by names only the health workers will be able to identify for matters of privacy. Here you can see that in particular there is 5% of mothers are high risk. At any given point of time, this is the number, very high level of high risk mothers in Meghalaya because of the conditions I mentioned, high teenage pregnancy, more gravidan, etc. And the state developed a system of architecture from the ground up. So at the village level, we have a team of people who are responsible for this. Any maternal or infant health issue, they are expected to discuss and take decisions at their level, which is headed by the village organization. And then comes at the cluster level, which is more about the A&M or the community resource person level, and then the block level, then the district level, and then the state level. At the state level, it is headed by the Honorable Chief Minister through the Human Development Council, but at the district level by the Deputy Commissioner, and even at the block level by the BDO, and their teams consistently form the issue. So the data which we were talking, each of the team discusses the same data. There is no different data, there is no argument about whether data is right, wrong, and etc. Everybody is seeing the same data, so the discussion starts from there and what is the plan for it. And this is the extension of the site, but the core team at the block level or the district level, along with the DC, these teams find the very important level, block development officer, child development officer. The most important point here is, it's a cross-sectional problem. It is not only health department problem, it is a department problem of the social welfare, it is an issue of the rural development, it is an issue of the, even for the matter, for example, law and order issue also. So that level we had to consider. So we put all the people who are in charge of it to take along this issue. So only then we will have that synergy to actually make changes. One of the main important things which we brought because of the lot of citizen-state interaction and the field interaction was that the existing schemes are not enough to address some of the systemic challenges. We introduced a scheme called Chief Minister Safe Motherhood Scheme, under which we gave dedicated vehicles to PHC-CHCs. They can hire vehicles, they can give the money to the community, they can give money to, we have given a lot of flexibility to them. Transit homes, because of geographical barrier, many women could not come on time. So they wanted to come ahead, they can come to a transit home, stay for even 2 weeks, 3 weeks, as long as it takes, along with their children. They were fed so that these high-risk mothers were taken care. And of course, village councils were encouraged to, if they are reduced teenage pregnancy, if they are reduced child-infant death, schemes are provided. And traditional birth attendants were also incentivized for bringing the pregnant women to the hotel. In this matter, we did not ask for Aadhaar card or bank account or that all we did not do, because most important is the outcome. Saving mother is important because many of the rural people in Meghalaya still do not have an Aadhaar card, bank account. For everybody is an issue. Most of the households are connected, but every individual person in the house having an account was still an issue. So it might be still a problem, but this, we made it matter that doesn't matter how the money is given or what you do it, but whether the child and mother is saved. That was the most important thing we measured. So we created a system of trust rather than a system of audit. So that's something very important in the scheme. And that's some of these things which I mentioned here. And the village health councils is something which we developed during this point, where the demand side, because maternal health we cannot only keep talking that it is the most important issue. We need the community to speak about it. Only the issue can be sorted out. Meghalaya, like many other northeastern states, communities are very, very important part of the society here, and they make collective decisions, and collective decisions stand together, and everybody follows. So that we took their confidence and we explained to them, and many of them have made a lot of change. And we did not form the VHC just like that, councils. We gave them a calendar of activities. What are the two things to do every month? So you can see a lot of topics which are there within health. There will be a person to explain to them, and there's a book, and after that they record what has happened in their own language or pictures and how they want to do. This is some pictures on the community health. Every maternal death, infant death used to be discussed at the village health council level, and what do they think about it. The medical officer goes and sits there, and then they initiate the discussion, and they feel and they would like to articulate, and we try to explain what would have gone wrong, what could have done right if it could have saved the mother. These are some of the initiatives. Also, we did transit homes, sector meetings, VHC meetings, and even we built up the operation theatres, FRUs, very closer to the community so that high-risk mothers need not go into complications. We also, this is a forum where a lot of states are there. We also have made an MOU with Tamil Nadu for training our medical officers in many important matters like emergency obstetric care, life-saving anesthetic skills, and ultrasound. Because we have a problem of specialists. This, I'm sure, is a problem with many other rural states. And we have trained more than 140 doctors in many of these courses, because we used to have only 15 to 20 ultrasound machines in all the government facilities before we started this. Today we have close to about 80, 90 ultrasound machines. Even in the remotest parts we have those, so that issues can be predicted. Because many of you are women here, 80% of pregnant women in Meghalaya did not get even one ultrasound check during their entire pregnancy. That used to be the case. So that's something we were able to correct during this. It's still some way to go, but been able to do. I'm trying to convey that this cooperative federalism is a very, very important concept for nation building, and this becomes very, very important, and we also helped us a lot. So what is the impact? You can see that there is a 41% increase of ANC coverage between the period of 2020 to almost 79%, from 56 to 79%. This has improved even further today. The CMSMS impact in terms of institutional delivery from 58% is over 80% today. And the maternal death reduction, 57% maternal death reduction in the last 5 years, 40% reduction within the infant deaths. This is the steepest decline of maternal and infant deaths recorded ever, at least as far as we know. We have checked wherever, globally also, in a place of a geography. This much reduction in maternal deaths and infant deaths has never happened. And so we took the issues, systemic issues, and we brought institutional solutions, not piecemeal solutions. When there was an issue with supply and medical equipment maintenance, we set up a corporation like many other states to establish and make it properly. When there was an issue with recruitment, timely recruitment, Meghalaya Medical Service Recruitment Board was started, and recruitment was done in a record time. And when there was issues in terms of resources, JSSV, we implemented the CMSMS scheme. Demand side, village health councils were instituted. So these things were done to make it much more collectively and to solve systemic issues with institutional solutions. So this is the future priorities where we still have work to do. We need to still focus on birth spacing. Still mothers are dying. Even 106 mothers is still a lot of big number. We have about 70,000 plus 80,000 deliveries around a year. So Meghalaya also has a lot of deliveries compared to for the population it has because of a higher fertility rate. And but we need to focus on early childhood development now. We need to focus, which my colleague will be speaking a little later. And we need to have a specialist issue for other issues, not only maternal child health. Non-communicable disease like cancer and etc. has become very, very serious. We need to focus on that with similar idea. So I'm just leaving back with this system building where the same framework, it's not definitely this important, but this framework we are trying to use for all the other socioeconomic problems. And we see that once implemented properly, this has a lot of impact, a lot of results and sustainable results. So I'll stop there. There's a short 2-minute video, so I'd like to play with the permission of the chair. Thank you.
Meghalaya faces a geographical challenge of providing healthcare services due to its difficult terrain. This difficulty in accessing healthcare services is a serious challenge.
In 2020, the state saw high maternal and infant deaths. During weekly COVID reviews, state leadership identified these deaths as symptoms of deeper gaps in the health system. In the same year, this led to the launch of the rescue mission with one core goal: saving mothers and babies. Each mother was tracked through the Mother app, ensuring timely care. Data was shared across health, social welfare, and community and rural development departments, fostering collaboration. Cross-department teams were formed at each facility, working with a shared purpose of saving lives of mothers and infants. Medical officers were empowered through the Chief Minister's Safe Motherhood Scheme, CM-SMS, giving them autonomy to use funds for life-saving interventions. Under CM-SMS, transport support helped bring pregnant women to transit homes where they could stay up for 2 weeks before delivery. Communities were engaged through the village health councils, making them active participants in their own health care. To reduce delays in doctor recruitment, the Meghalaya Medical Services Recruitment Board was established. The state government also signed an MOU with Tamil Nadu government to upskill medical officers in life-saving obstetric care. Through the rescue mission, the entire health system was strengthened, leading to a significant reduction in maternal and infant deaths. The lessons from this initiative have been institutionalized into the state capability building model, a framework for solving complex challenges using existing resources more effectively. The state capability building model can be adopted to solve other complex problems and help create systems which ensure that the problem stays solved in a sustainable manner.